Welcome back. The first part of Lesson 8 was on late-stage Parkinson's disease and access to best care at the end of life. This is the second part of the 8th lesson related to advanced Parkinson's disease, death, and dying. Part 2 focuses on a question of whether home is always the safest place for dying and open communication-related challenges that may arise in late-stage Parkinson's disease. This session tackles the question under which circumstances home is considered to be a safe place for dying. Another important subject is the necessity for professional carers of being open-minded and flexible in answering questions which may arise in the course of the disease. In this section we invite you to expand your understanding about the home as the best place to die. We mention few historical anchor points that have led to exploiting the notion of home in palliative care and provide few examples, why the usage of home concept might need critical revisiting. Politicians and governments seem to support the idea of expanding outpatient care services, including providing end-of-life care at home. In fact, the place of death has become a key indicator of good end-of-life care. This drives the aim to reduce hospital dying and to increase the number of home deaths. When discussing with patients about their preferences at the end of life, many tell that they would like to stay at home as long as possible. However, regarding the final weeks of their lives, many would choose to go to hospice or hospital because they do not want to burden their caregivers or would feel safer having access to medical and nursing services. Other patients again find the idea of going to hospice unacceptable, as hospices represent to them abandonment and failure. It is the task of medical and nursing professionals to inquire about and understand patients' preferences and help patients to find the best possible solutions. Therefore, we believe that all medical and nursing students should be involved in providing home care during their training, in order to learn that the places where people live hardly are comparable with their own notion of home. Being part of the home and community care teams might also help to understand why a home might not be the best place to go, or be, when seriously ill or when dying. Let us take a look at places where people might spend their end of life to increase awareness when involved in decision-making negotiations. Why are some people afraid of hospices? In fact, hospices have a long history and many of those dates back to the 12th century, provided as a refuge for the homeless, people suffering from malnutrition, extreme poverty, orphans, women in labor, and sick people. Perhaps the most established hospice form was for leprosy patients, where besides religious rituals, strong pain medicine was administered to provide comfort care. Albeit provision for terminal care already existed in the organizational work of hospitals, those provisions paled in the face of the overarching social dynamics of healing and saving. Accordingly, in the late 1950s and during the 1960s the palliative care movement began to flourish in many countries. Because of the history of hospices, the main contributors at the birth of the modern hospice movement were Protestant deaconesses, Catholic nuns, and social workers, who aimed to improve the end-of-life care of dying patients by providing comfort care. Their main effort was to contribute to out-of-hospital communities, where dying persons would feel neither strange nor neglected. According to Saunders, hospices should provide the home-like environment as a contradiction to the cold and impersonal hospital setting. Modern hospices are designed to meet cancer patients' needs. Until today the hospice stay is limited to 6 months. In fact, that means that patients are referred to hospices very late, somewhere around 2 weeks before dying. Patients with heart failure, neurodegenerative diseases, or dementia are seldom referred to hospice. Most often people with non-cancerous conditions find themselves receiving home or community hospice care services or are moved to long-term care facilities. Yet, around 20% of patients having access to palliative care services die in ICUs, which certainly calls for some reflection. Palliative care in the intensive care unit or ICU is a widely discussed topic and it is increasingly applied in clinics. It encompasses symptoms control and end-of-life management, communication with relatives, and setting goals of care ensuring dignity in death and decision-making power. However, effective application of palliative care in ICU presupposes specific knowledge and training which anesthesiologists and critical care physicians may lack. Moreover, logistic issues such as protocols for patient selection, application models, and triggers for consultation of external experts are still a matter of debate. Ethical conflicts are commonly encountered in the course of delivering end-of-life care in the ICU. Some ethical concerns have legal dimensions, including concerns about inappropriate hastening of death. Despite these concerns, many ICUs do not have explicit policies and procedures for the withdrawal of life-sustaining treatments. Death at ICU is resource-intensive, including the human resources working the ward. For example, the main stressors among the ICU nurses confronted with death are the lack of resources and time to attend to the needs of patients and relatives. The stress, which relatives suffer, is associated with subsequent development of anxiety, depression, and post-traumatic stress disorder that may persist long-term. Stress and anxiety are unlikely to be lessened by enforced absence and may deepen the distress of dying and bereavement for patients and relatives. In addition, the non-acceptance of dying on the part of the medical practitioners has been reported as burdensome. Concerning coping strategies, a lack of sufficient strategies, and a lack of offers on the part of the institutions, is a huge deficit. Therefore, the organizational focus should be on providing staff training and other coping strategies to maintain the health of the employees and to improve the care for the dying. A growing number of people die in aged care facilities. The advanced care planning and development of palliative care services have led to a significant decrease in non-elective ICU visits at the end of life, which means that residents may actually die in long-term care homes. Many of such care facilities deploy the myth of a home-like environment. Referring to the residents' rights in healthcare indicates the rights, duties, and obligations exercised in a relationship between resident and nurse, resident and doctor, or resident and care provider. The residents' rights to choice, decision-making, and risk-taking are highly regulated, because the nurses, doctors, and providers should offer safe services. The care home is an institution, and when a resident enters an aged care facility, they often begin a slow but steady downhill journey where free will and decision-making are slowly stripped away until they can become quite dependent. For the late stage Parkinson's patients, care homes seem to be a comfortable solution, which reduces the caregiver burden and gives people with Parkinson's disease an opportunity to take part in few social activities. However, we know that elderly care facilities are not accessible in many regions. Good end-of-life care in nursing homes depends mainly on a skilled and trained workforce. Without going more deeply into these socially burning questions, few questions for self-reflection. Where do inmates die? Where do homeless people die? What about refugees, and undocumented migrants? These questions should demonstrate that it is problematic to equate the home with good dying. Numerous people are not able to voice their wishes, do not have a choice, or do not have any preferences regarding their place of death. Therefore, it is essential to challenge our understanding of home. Rinsk Visser is a medical anthropologist interested in the meaning of home, aging, dying, and death. She has written that death at home is not always a good death, but as deaths in usual place of residence are statistically considered good deaths, this does not offer space to think of the complexity of home deaths. She continues, death is always messy, and the idealized image of home does not help foster discussions about people's wishes. Research on people's wishes regarding the place of death is limited, and does not account for the fact that people might prefer to die in a hospital but are afraid to say so, or that they might change their minds about what they want. As we are all dying for the first time, we can mainly decide on things we don't want based on what we have seen with others. Hypothesizing about our endings is complicated, and there is little space to be inconsistent about how and where you want to die. It is therefore not surprising that people hang on to home, as the imageries around this word are linked to safety, comfort and relationships. There are numerous examples of the statement that the majority of people want to die at home in the news, academic articles, and popular culture. What people mean when they say this is rarely unpacked. If we acknowledge that our understandings of home are individual and might change over time, we can also give space to the idea that what we want at the end of life is individual and might change. For example, migrants might think of returning home when growing old, but this may never come true, as the social security net, friends and family as well as access to healthcare might feel more sustained at the current place of residence. Visser argues that as we are experiencing life and death for the first time, we are all making it up as we go along. Remember, feeling uncertain about your hypothetical ending is completely fine. So, it is a matter to discuss as a part of advanced care planning in Parkinson's, what is acceptable and what is not. This section focuses on the openness to answer questions concerning the late stages of Parkinson's disease. Furthermore, this lesson should encourage readers to understand why caregivers and patients might need extra support in this phase. According to the consensus recommendations by Oliver et al. On communication with patients with chronic neurological diseases and their caregivers, communication should be open from the point of telling the diagnosis throughout the disease trajectory. The setting of goals and therapy options, as well as advanced care planning, is strongly recommended. Especially when impaired communication and cognitive deterioration are possible as part of disease progression, this should take place rather early. In order to avoid crisis intervention, physical and psychosocial issues should be proactively assessed on a regular basis by the treating medical team. At the end of life, the recognition of deterioration in disease progression is essential in order to enable appropriate care and support for patients and their families. Both patients and families may have fears of a distressing death from progressive neurological disease like Parkinson's disease. However, this situation occurs rarely, if good palliative care and support is installed. Families do appreciate honesty in communication and the awareness of deterioration. Symptoms and other issues can be managed effectively by a multidisciplinary team with experience of specialist palliative care, and death for the majority of patients is peaceful. Honest communication and the willingness to answer questions of both patients and caregivers openly is key. Treatment of early-stage Parkinson's disease is entirely different from later stages. Early treatment regimes aim at prevention, symptom relief, prolonging survival, and prevention of motor symptoms. In the later stages, however, the focus of treatment shifts to treating non-motor symptoms and having a more supportive and palliative nature. Several medical issues might occur and can relate to pharmacological problems with absorption or end-of-dose wearing off of levodopa. Motor complications might become more prominent and affect emotional health and well-being, as well as mobility and independence. Pronounced hyperkinesia can cause social stigma and lead to social withdrawal. In conclusion, medical issues in end-stage Parkinson's disease differ from earlier stages and have a high impact on the quality of life for patients and caregivers. As the patient approaches the end stage of the illness, the main goal is preserving autonomy and stress relief by managing motor and non-motor complications according to the principles of palliative care. Around 40% of patients with Parkinson's disease develop dementia in the late stages of the disease, and psychosis is common. These Parkinson's disease patients suffering from dementia and psychosis are more likely to be placed in a nursing home and are also at an increased mortality risk. Also, depression and anxiety are rather common complications, with up to 40% of all Parkinson's disease patients affected. Possibly, the rate is even higher among end-stage patients with increasing motor complications. If psychiatric complications occur, this also affects the quality of life of caregivers. Caregiver burden in Parkinson's disease correlates with increasing patient dependency and disability, depression, hallucinations, and falls. Therefore, psychiatric complications affect both patients and caregivers and should be identified in a timely manner and treated effectively. In the end stage of Parkinson's disease, non-motor symptoms become more common and can become the most prominent medical problem, leading to an increasing decline in quality of life both for the patient as well as increasing caregiver burden. Non-motor symptoms occur in up to 50% of patients with Parkinson's disease, especially in association with the medication off state, and may become worse by anti-Parkinson's medications. Almost one-third of patients report their non-motor symptoms to be at least as debilitating as their motor symptoms. Non-motor symptoms include impaired swallowing, weight loss, constipation, urinary urgency, forgetfulness, dribbling, sadness, hallucinations, anxiety, sexual dysfunction, falling, reduced concentration, daytime sleepiness, vivid dreams, and sweating. In advanced patients with Parkinson's disease, the focus of treatment shifts to treating the predominant non-motor symptoms and having a more supportive and palliative nature. Unlike earlier in their disease, patients in end-stage Parkinson's often are dependent, frail, and have poorer quality of life. Symptomatic treatment might not be as effective anymore and aims mainly at providing the patient with comfort and support. Moreover, ethical dilemmas related to withholding or withdrawing life-prolonging treatment might occur. Although morally similar, withholding and withdrawing treatment might be perceived differently by caregivers. Open communication and information of patients and caregivers are essential. In some cases, caring at home might not be feasible due to increasing disability and dependency, or neuropsychiatric complications like psychotic or harmful behavioral symptoms. Institutional care might then be an option to minimize stress for patients and caregivers. In conclusion, end-stage Parkinson's disease can be emotionally and physically challenging for patients and caregivers. Extra support should be offered in the final phase of the disease. To provide best care to patients and their caregivers, acknowledging the importance of individual patient-family-centered approaches, and not stereotyping patients and their families based on their culture, sex, religion, or ethnicity is essential. This is in accordance with palliative care philosophy, which suggests that approaching the patient as a whole, emphasizing on the humanistic aspects of care in terms of hope and life, reducing of the feeling of loneliness during hospitalization, paying attention to patients' needs, sympathizing and respecting them, and taking their concerns seriously, will promote the feeling of safety in patients and relatives.